So just like to very much welcome so many of you here in the audience today. My name is Jenny Hyam. I'm the Vice Chancellor of St George's. And I think one of the great privileges and pleasures associated with university, there are some negative aspects, but one of the very positive aspects is the identification of people who are stars and their onward progression and promotion. I always like to take a moment to ring those that have been promoted to a professor, and it was a fantastic time to speak to you, Dan, because you and I have had a lot of interaction over the years that we've been here, and I think you're just so tremendously worthy of this accolade. You have a long and illustrious career, which we'll hear about. You also have to do your inaugural, which is so unlike so many other lectures one gives, because it's to a much more varied audience who probably don't want to go too much into the basic science or delta subcategories. And you also have your family with you who'll be slightly pleased and cringing as things go on. So you're a consultant hepatologist, and in fact our paths over, like, we were both at Imperial College, and there you did your science and research initially on the manifestations in the brain of chronic hepatitis C infections. We would have known that you were a future star because you got a research medal from one of the most famous names within medicine, that of Dame Sheila Sherlock. You've continued your research around hepatitis and the biological effects of hepatitis C. And it was fantastic for George's that you decided to move here in 2005. And together with colleagues and science and medicine are team sports. It's wonderful that we've got Dr. Sarah Clark here. Sarah is an NHS consultant colleague and great partner of Dan's, and she will be giving the vote of thanks at the end of the lecture. So Sarah will then come. And on that point, you also aren't going to have the opportunity to ask questions at the end of the lecture because it is an inaugural lecture, but you have endless opportunities to ask Dan any questions that you like in the drinks and refreshments afterwards, which are just diagonally across the hall, so you'll be invited to that later. I hope that Dan will cover many of these things in his talk, but he's been so fantastic for his leadership qualities. Director of acute medicine, Associate Medical Director for Research since 2011, spearheaded our clinical research facility that was accredited by the NHR in 2022. And yes, alongside all these leadership roles and really banging the drum for research, to a trust board that has been very receptive, alongside which you've continued really important work on viral hepatitis in the community, and very importantly with an aim to eradication. So I've been pleased and delighted to work alongside you. Look at the size of the audience and that online. You are full of anticipation of what you're about to say, and
Professor Hyam, thank you so much for those very generous words. Ladies and gentlemen, it is a deep honour to be invited to speak to you today, and I'm actually humbled by the number of people that have chosen to be up there Monday evening to come and hear me talk. You might think that this picture refers to me a week or so ago the hottest weekend of the year trying to put together this talk, but he doesn't, although he wouldn't be far wrong. I'm going to come back to him. My title, How to Cure Disease, has provoked a few comments, actually. People have said, only being a bit expansive here, Dan, a bit ambitious. But I thought, no, because cure is a short word. It's a very big word. And I think it really relates to the incredible story, the unprecedented arc in medical history of the discovery of hepatitis C, the generation of highly effective treatments, to the point that we may one day eliminate hepatitis C from this earth, even without a vaccine, or at the moment, the prospect of a vaccine. So by any definition of the word, to restore health, to bring about recovery from, to eliminate or rectify, or to free from something objectionable or harmful, I think the title stands. And this arc maps onto my career. And that's what I'm going to talk about today. The impacts of some of the science around hepatitis C, and then the delivery. I'm not going to talk too much about this third definition here, fish cured with salt, only to say that I'm a great fan of salted fish, backpacks, dill sauce. As we've heard, hepatitis C now is a target, elimination as a public health problem from the WHO. And the target is defined in a way which is changing most years, but I think certainly for some of the aspects of this, we are on the track to at least reach some of this in the UK, maybe not globally. So I'm going to start with this manuscript, which was given to me by John Eastwood, Professor of Renal Medicine here at St George's when he retired. And he published this in 1968, which was the year that I was born. And it describes an outbreak of hepatitis in the Fulham Hospital on the maintenance hemodialysis unit. 14 out of 27 patients developed clinical or biochemical hepatitis, with one death. And there were similar outbreaks around the world, in Brooklyn, in Manchester, and Liverpool. And what I love about this paper is the meticulous detailing of what happened, an old-fashioned description of how they thought this virus had spread from one person to person. Case 1 was ill for 1 week before a diagnosis was made. During this time, she and the patients in cases 2 and 3 had been in the habit, while being dialyzed, of playing Scrabble. It's a game that involves the passing of a board and counters among the patients. And the thrust of this paper really was to determine whether this was infectious or serum hepatitis. Quite a question, given that none of the agents that are responsible for those conditions has yet been discovered. Hepatitis A, hepatitis E, hepatitis B, hepatitis C. They knew about EBV, Epstein-Barr virus. They knew about cytomegalovirus. And actually, it's very nice to see that the titers for hepatitis C were sent to the old St George's Hospital to a Dr. Stern. When he retired, he wrote on the bottom of this paper that it predated the Australia antigen or the discovery of hepatitis C. And in retrospect, this disease was probably hepatitis C. So I'm going to go quite quickly through this, but hepatitis B was essentially diagnosed in 1968, and sensitive tests were developed. But when they applied this test to screening of blood samples, it only reduced the incidence of hepatitis by about 25 to 50%. And then when hepatitis A was discovered, it really didn't impact. So there was still a blood-borne virus that was initially termed non-A, non-B hepatitis. And it was in 1989 that this seminal paper was published where hepatitis C was diagnosed. This was the first what was discovered. This was the first discovery of a virus that didn't use traditional tissue culture, but was discovered by new, at that time, molecular techniques using random primers. I'm not going to go into this too much, to identify a single clone out of more than 1 million that was screened. And this led to a very rapid advancement in the science of hepatitis C, with the sequencing of the virus, with the development of tests, and then a good natural history of this infection. And we knew pretty quickly that this was a chronic infection that affected most of the people that got the acute infection, and that over a period of around 20 years, 20% of people develop advanced fibrosis and cirrhosis of the liver, and that is the point at which there's an annual risk of developing liver cancer and liver failure. Now, I was at medical school at that time, and to be honest, it all just completely passed me by. I wasn't aware of any of this until finals, when I was in my little attic flat in Newton Green in North London, and preparing for a viva. We used to have a viva in medical finals, where in theory they could ask you anything. In practice, you read a couple of papers and then had the opportunity to talk about those. So I read this paper the night before the exam, and I still remember it very well because it came up. And looking back at it now, there are a couple of things that really seem very salient to me. So one of the things they were talking about was the clinical utility of this new molecular technique, RT-PCR, essentially amplification of the viral genome to determine whether the virus was present. They concluded that there is rarely a need to employ this methodology. How wrong they were, because it's a standard test now. But I didn't know at that point that I would dedicate 2 or 3 years of my life trying to optimize this technique later on in the laboratory. The other thing which was mentioned was that there was a treatment with a drug, a cytokine called interferon. And that brings me to Howard Thomas. Howard Thomas, ex-professor of medicine and hepatology at St Mary's and Imperial. I did my first registrar for him, and I'm so pleased that he's travelled up from Dorset today to come here to be with us. Howard actually and his group did the first randomized controlled trial of interferon on patients with non-A, non-B hepatitis. So they were trying a treatment for a condition that had not yet been defined. And again, this is going to be a bit of a recurrent theme. You can see the meticulous care to measurement of the response in these patients. Just measuring the AST after treatment, it dropped in a good proportion of patients who were treated. This is a clear controlled trial, but in the control group, no impact. So interferon is an antiviral cytokine. It's poorly tolerated with really terrible adverse effects. The treatments are lengthy, up to a year, sometimes more. And there were very poor response rates at that time. Maybe 20% of people responded. But it did remain as the backbone of antiviral treatment for 20 years up until 2011, when we come on to the new drugs that I'm going to talk about next. So I can't have done too badly as a registrar, because he invited me back a couple of years later to be a clinical fellow, research fellow, and put me to work with 2 supervisors. Simon Taylor Robinson, who many of you may know, and won't be surprised to hear that he's somewhere in Algeria at the moment, had developed expertise in the application of magnetic resonance to brain and liver in patients with liver disease. And Peter Karianis had green fingers when it came to molecular virology in the lab. Peter now is a professor of molecular virology in the University of Nicosia. He may be online. I'll be very happy if he is. And it was with Peter that I spent those years in the laboratory trying to optimize PCR. So now I come to that picture. This was all about hepatitis C and the brain, as you've heard from Professor Heim. And Howard gave me this project. It was a bit of a blue sky project at the beginning, based again on very careful observation from Mary Crossy, his senior nurse, who noted that people with hepatitis C had a much higher burden of cognitive problems, brain fog, we describe it these days, compared to people with hepatitis B. And in fact, did much worse on interferon than people with hepatitis B who tolerated it quite well. So there's something about the virus that affected the brain. And this was studied a bit more systematically by Graham Foster, who showed that people with hepatitis C had lower quality of life across all domains compared to hepatitis B, and controls independent of the presence of liver disease. So I set about at the Hammersmith Hospital applying NMR spectroscopy, an MR technique that allows metabolite measurements in the brain in patients with hepatitis C without cirrhosis. And that's very important because we know cirrhosis causes this condition called hepatic encephalopathy. And you can see you can measure various chemicals in the brain. And what we thought we were finding, what we found, was there was an increase in some of the inflammatory markers in people with hepatitis C compared to hepatitis B in control. And this made it into the Lancet. It was my first research publication, and you can see I was pretty pleased to keep going. Now, at that point in time, Julia and I, Julia sitting in the front row, had moved to Shepherd's Bush, and you can see it's just a short hop, skip and a jump to the Hammersmith Hospital from there. And that was pretty handy for me. And it was even more handy when Julia was pregnant and booked in there. It meant, you know, well, the labour ward was just down the corridor from the MI unit. So very convenient. But there was an immersion problem on the horizon, not a problem, but a decision, because I've been fortunate in my abstracts of getting an oral presentation at the presidential plenary at the EASL meeting in Rotterdam that year. It was going to be on April the 30th, which was Julia's due date, April the 30th. So I called Simon, and, you know, Simon, you're going to do the talk. But Mia actually helped me out because she came early. She came on April 20th. Had some neonatal jaundice and was in hospital. It's not so good for her, but great for me. Story goes on. I thought, well, I'm going to go. So I got this really expensive, day return ticket to Rotterdam. Getting ready, and the night of the 19th, just packing my bits and pieces together, I noticed my passport had run out. This was a while back. It was pre 9/11 and everything. Things were a little bit looser in those days. I thought, well, I'm just going to have to ring Simon and tell him that he's going to have to. Then I thought, no, I'll ring the Rotterdam Border Force. So I gave them a ring, and they said, "Oh, yeah, just come along and." Just your passport. So that night, I went back into the Hammersmith in the middle of the night, found the facts, sent them the passport, and then I was on the plane the next day. Got to Rotterdam, down the steps. There was a nice guy there, and just like, "Good morning, Dr. Forton. Come along with me." And he went, through this little back route, and I was on the other side of the airport, on the bus. Did my talk, which I think went quite well. Had a beer in the sun with the team. Back on the flight home. It was one of the best days of my life. Not as good as the day in meals. So the question then was, so what? We've got these metabolite abnormalities in the brains of these patients, but does it mean anything? So we did work with neuropsychologists and cognitive testing, and found that there was indeed impairments in attention and working memory, which appeared to correlate with the MR abnormalities. And I continued this work when I came to St George's, and Marcus was my first fellow and did this work and reproduced the findings and showed it actually was only the symptomatic patients, probably only a third of patients who had this cognitive abnormality. And Marcus was appointed as a consultant at Kingston Hospital and still joins us on a weekly basis in the liver clinic and on the piece. So I've maintained an interest in this area and been invited to write commentaries and reviews. And this top one was done with a couple of very talented medical students doctors at St George's, and the bottom one in gastroenterology was with the slightly more eminent people in our field. So what did this mean? Well, it meant that perhaps we were going to focus our treatment not only on people with end stage or advanced liver disease, but at an earlier stage of liver disease. And this trial, which was run by Mark Thurs in Howard's group, really showed for the first time that it was cost effective. There was a benefit in treating patients with mild hepatitis C. And I think this is one of the first HTA funded trials in liver disease that was successfully carried out in UK hepatology. So really, I'm going to come to an end of this section very briefly, but just to round it up, the question really was this a biological phenomenon? Was it the impact of inflammation or something, or what did the virus actually cross into the brain and replicate or reside in the brain as a sanctuary site? So the logical next step was to look at post-mortem material, and it was possible in those days to do this type of work from brain banks in Glasgow and at Imperial College. And about 3 years of work is summarized on this one slide, and I'd like to tell you a lot more, but I'm not going to. But we showed that there were specific variants in the brain which were different to liver and serum, consistent with viral penetration into the brain, and others afterwards. And we looked at microglial cells, and there was evidence of infection. Peter really trained me. He really supported and helped me to get these techniques to work, and I'm forever grateful to him, and also my friend Emanuele, who was doing similar work and suffered in exactly the same way. We both shared weeks of experiments not working, and he cheered me up. So I'm not going to say anything else, because we are now at the dawn of a new era, a dawn of an era when we are able to identify potential targets for antiviral therapy. And this was because of the formation of a replicon virus that was an engineered virus that could replicate in tissue culture and open the floodgates for all of big pharma to start developing compounds against hepatitis C. Now, other momentous things happened in 2005. Google Maps came along, and I could dispense with my A to Z. And you look it up, it's true. And Google Maps showed me the way south to St George's. And I was appointed consultant hepatologist at St George's to join Sarah Clark to develop the service here. And it wasn't long before I discovered what a fantastic hepatologist Sarah is, and what a fantastic friend she was and remains. She doesn't just pass the friends and family test, she excels continuously at the friends and family test. If you had a patient with a sick liver, you'd want Sarah at the end of the bed directing their care. But she also has this steely determination, which I think will be familiar to a lot of people, which has, amongst so many other things, driven our department to be one of the first in the country to be fully accredited were equals, which is a quality assurance service run by the Royal College of Physicians. So we set about developing tertiary hepatology at St George's. The third important thing that year was Henry's arrival, joining Emily and Mia. It's quite a big year. So I came as a hepatologist, but quite quickly I did a bit of a swerve, which I didn't expect, into acute medicine management. And I think this was because I saw an opportunity, and this is perhaps a theme, an opportunity to modernize and reshape how we admitted patients with the formation of an acute medical unit and actually a rebuild, an extension to this. And well, it seemed to go quite smoothly. It just happened. I don't think there was a business case. I mean, somebody else must have written it if there was. But what I learned from that was that if you can align what you want to do with what your organization needs, or convince them what the organization needs, you can get somewhere. Business case, those are sometimes unwelcome words if we want to make progress rapidly in the NHS. The second opportunity was a return to one of my great loves, but which was not Nick Tatman. But the appointment of Nick Tatman as our hepatitis nurse in 2007 really helped us get back in the game of treating patients with hepatitis C. Back then, Nick was a very experienced hepatitis nurse, had treated lots of people with interferon, had done trials with Nikolai Naumov. And now, what I think he is the oldest and most experienced and knowledgeable and slightly weary CNS in the country. This picture was taken last week, and I think he looks very good. So the opportunity here was to develop St George's as a centre for clinical trials for these new antivirals. And we started off small, really just me and Nick working together on these three new classes of drugs, which you can see here, the protease inhibitors, the NS5A inhibitors, and the polymerase inhibitors. And lots of compounds came and fell by the way. And this one sticks in my memory. It was an early protease inhibitor from Roche, ritonavir boosted tenofovir. You don't need to know that. But you can see that on treatment by week 4, 96% of patients had already lost the virus. Now, we had a patient who unfortunately developed a lung condition, a pneumonitis secondary to her interferon, and had to stop treatment at 4 weeks. But she went on to have a sustained virological response from just 4 weeks treatment. And we were absolutely astonished by that. And that's when it really came home that there's going to be a cure for hepatitis C. So I made this, thanks very much, David, for coming. He's going to the theatre. Much better choice. Great choice. So I made this slide in 2013, and you can see here that we'd enrolled 44 patients into all these different compounds, often still with an interferon backbone, and I don't think any of those actually came to market in the end, and mainly phase 2 studies. But you can also see that we had a 95% cure rate. So what we were doing was actually really benefiting patients, and this drove huge interest amongst our patients to come forward, and it wasn't difficult to recruit people into clinical trials. Mericitabine, you can see there in the middle, was the first very weak polymerase inhibitor, which presaged really the main drug in hepatitis C, sofosbuvir, which was the first £1,000 pill this was the initial cost and caused some discomfort amongst us, doctors, and patients. And in clinical trials, we were really very careful giving it out. One patient left his whole supply on the tube, I remember. But actually, pharma moved very quickly to making generics for developing countries, and the costs came down through contractual collaborations, particularly in this country. So we did a lot of trials back then, and I'm not going to go through all of them. You'll be very pleased to hear. But what I want to do is just illustrate how we try to tailor our portfolio to our local population. Genotype 3 is a strain of the virus which is common in Southern Asia and Pakistan, and here in Tooting, we had many patients with this strain of the virus. So this was a trial which was led by the UK, 80 sites worldwide, where we were treating people without interferon in all arms. And you can see that we were achieving very, very good cure rates in our patients who had cirrhosis and genotype 3. That was the hardest group to treat. That was published in Gastroenterology, and this was another UK-led study combining one of each of the three main class of drugs before the current drugs eventually came along. And you can see here 100% cure rate. And that's a cure. And I practiced that. And the rest, they say, is history and politics and money and commissioning and decisions and screening and diagnosis and linking to care and deployment. So a huge amount of work followed all of that. But in research, we expanded our portfolio. This slide hasn't come across very well. You can maybe just see the numbers, which showed the number of trials that I did over the next few years, maybe 100 trials recruiting over 600 patients and giving access to leading compounds in hepatitis B and fatty liver to our patients. Now, you can't read that list of trials, but the one person who knows exactly what they all were is Hannah Ryan, sitting up at the back next to Nick, who joined us in 2016, I think, as a clinical trials coordinator. And her work, together with a series of fellows that have helped and been very engaged in this program, is the reason that we've been able to achieve what we've done. It's all about teamwork. So back to the clinical service. And in parallel, we'd been working with colleagues in interventional radiology to establish more tertiary flavored services. We established a TIP service, which is a stent for complications of cirrhosis and portal hypertension, new cancer treatments for liver cancer, chemoembolization, and ablation. We were pioneers with FibroScan, one of the first units in the country to have this, and really integrated it into our clinic and formed a widely recognized, excellent, benign weekly hepatology, radiology, NDT, which I'm sure the trainees in the audience will tell you has been an exceptional educational resource. And we became a specialized commissioned hub for hepatitis treatment in South London. In 2014, the late Roger Williams asked me to join the writing group for this first Lancet commission into the state of liver disease in the UK. And I think this was an important document because it has kind of been the route map for what a lot of the developments have been in this country. And the commission described the extent of the problem of liver disease. You can see here that liver disease is the only area, was the only area, and probably still is the only area where mortality has been increasing, whereas all the other main disease groups, it's been coming down. So we wrote about the current deficiencies in both the community primary care and hospital services and provided a blueprint for how that might improve. And 2 or 3 of the key recommendations have kind of looking at this, sort of formed what I've done in the second part of my career, strengthening the detection of early liver disease and its treatment in primary care, improving support services into the community, establishing specialty liver units beyond the small number of transplant centres in this country, and the eradication of viral hepatitis. So it was very satisfying for Sarah and myself that the Commission chose St George's as an exemplar of a specialist liver centre in that publication. And I think is a very important reason why we were able to attract our next hepatologist, Dr. Sarah Hughes, who was appointed just after that came out as a hepatologist with an interest and lead for portal hypertension and our transplant link into King's. Now, Sarah is a very fine hepatologist and a very fine person. And you'll see here that she's not wearing hepatology or gastroenterology on her top, but intensive care. And I think I'm right in saying that she was the only physician in COVID that had the skill set and the willingness to put herself forward to be an intensivist in the first wave in that frightening time, and dedicated herself to, thankfully, she survived and she came back. In 2012, I was appointed Associate Medical Director for Research, perhaps on the back of some of the actual stuff that we'd been doing. And I've written or led the writing of a couple of research strategies, the first 2013 to 18, and then our most recent one, which I think is the one I'm going to talk about because it's the more successful one. And as Professor Hyam said, that was the case because we had good engagement from the Trust Board and very good engagement from the university, from John Friedland, the Vice Chancellor for Research, who's sitting to my right. And before we wrote anything, we asked our staff what we should do and what they thought. And I think that was really important. 420 respondents, Trust staff, responded to this survey. And it wasn't just doctors, half were allied health professionals and nurses. And there was very broad agreement that research is actually of value because it leads to better outcomes and higher quality of clinical care, that opportunities should exist across the breadth of our services for patients. It's important for our reputation, and it's important for our staff. It gives them interest and value in their work, helps recruit and retain high quality individuals. Now, there were barriers that were noted. Investigators and staff wanted to have more time for clinical research. There was overwhelming support for allied health professionals and nurses to lead their own research. Barriers were money, as it always is, and a poor IT infrastructure. So we wrote a strategy, and these are the main strategic objectives. Now, you're rarely in a position to mark your own homework, but please indulge me, because that's what I'm going to do. I gave an A. I gave an A for the first objective, which was to plan, seek core NHR funding for our clinical research facility. We planned to do that. We put in a good application and we achieved that. I'm going to give an A for establishing a clinical research institute, our translation and clinical research institute, a new virtual institute for everybody who was research active in the trust to foster and grow them. I'm going to give a B for the other three objectives because we have made real and good progress, but we can still do better. So I think those are pretty good grades. I think you can get into St George's Medical School with them. So I'm going to talk a little bit more about the CRF, okay, the Clinical Research Facility. We were strategic about this, and I have to say, great thanks to the Trust Strategy Department. I never thought I would say that, but it was definitely true. Ralph, Michelle, and Catherine Brooke really helped us plan this application. It was invaluable what they brought to the table, and helped Kath Cosgrove, who's the co-director, and me to put together this application. Addy, who was our CRF manager, has now left, but was also a key person in doing this, together with John and the university as well. So it brings delight to me to see these letters on our doors in the CRF. We were awarded a sum of money for 5 years, and our objectives now are to increase early phase and experimental medicine studies, to roll out a multidisciplinary research training program, to establish patient and public involvement infrastructure, and improve the diversity of clinical trial participants in the trust. And we have a very vibrant, exciting staff group in the CRF, led by Tinashe Samakonva, who's our head of research nursing. And they have a positive attitude and want to grow, and we want it to grow. We've received further funding to improve the infrastructure, and we have plans for that in the next year. So come and visit our website. You can see a daily tally of the patients that we've recruited into trials in the CRF, and meet the team. These are just the top 2 rows of a very large group of people. When I started as the R&D director, we only had 2 members of staff in our nascent CRF. And TACRI has been a success, and I'll go through that in a moment. And I was delighted to hand over the leadership to Debbie Banerjee, who's a trialist, a renal physician, and Heather Jarman, who is our Director of Research for Nurse and Allied Health Professionals. And now it is really going some 250 members, and provided a statistical support service for NHS researchers in collaboration with the university. We have a research seminar series through the Grand Rounds, a TACRI manager who helps people new to research to get their studies up and running. And this is where money counts. The trust has invested in our staff, and we have funded junior and senior research fellowships for NHS staff to gather data, to put together grant applications, and 12 chief nurse fellows buying time back from nurses, allowing them to get a start in delivering their own academic agenda. So what has this kind of investment and reorganization meant? Well, you can see here the number of patients that have been recruited to studies at St George's over this period, and the number of clinical trials that we've done. And there's an upward trajectory. You don't need to do a statistical test, but you can see the impact of COVID there in 2021. And let's talk a little bit about research in COVID. Everybody in this room will remember what a frightening time that was. Our researchers really came together, and there was a focused effort in the university and PIs, the clinical research facility, our joint research, the R&D support function, to set up and deliver COVID trials as quickly as possible. I convened a research prioritization panel with key people in the university and the trust, and this was not only a very helpful source of advice as to what we would do, but also began to have ideas ourselves about how we should proceed in dealing with this. We did well during COVID, and at times we were running more COVID studies than any other organisation in the UK. We ended up 5th nationally for the number of urgent public health studies we did, and recruited over 8,000 patients into clinical trials. The CRF worked so hard, but so did many other people. And one of the things that I kind of feel most proud about at this time came from that prioritization panel and others, Kamal Patel in particular. I'm not going to say the word, but gastroenterology. He was scouring the net and social media and looking at what was coming out of Italy and China, and others had heard about tocilizumab, IL-6 receptor blocker. And we put together very rapidly a protocol for a kind of compassionate access program for tocilizumab, which we eventually published. And I think this was the first report out of the UK of the use of tocilizumab before the big trials even. Well, we did this before the big trials started. That was the justification. And I've got Emma Baker here as well, because Emma was so helpful in continuing the tradition that I've been trying to allude to of meticulous clinical observation, of measuring patients' variables. And you can see here graphically how the maximum daily temperature of the patient, their arterial oxygen relative to oxygen flow, their CRP, how it's all dropped down in the majority of patients that we selected according to our criteria for tocilizumab. And here we can see the outcomes for these patients. It's not a trial, okay? It's an early experience, but at that very scary time, only 2 patients died and the rest were discharged. And this was valuable for some of the information, but it was also very valuable for our people. It gave succor and it gave encouragement at a time which was so very difficult. So I need and really want to credit the people in the Joint Research and Enterprise Service, not just for their huge work during COVID, but actually behind all of these data. You know, the achievements of our clinical researchers could just not happen without the R&D function here. And Mark was appointed, I think, in 2016, and then appointed Sabir and Louise Phillips to head up governance and delivery and research funding and their teams. So ultimately, the whole of the JRES has changed now. They're not often recognised, and I think it's really important for the record to say what a great job that they do. So back to hepatitis C now. I have to come back. We saw unprecedented rapid progress from discovery to cure, and this paralleled huge advances in molecular science. And this was a testament to collaboration between the academic researchers who got Nobel Prizes, pharmaceutical industry and clinicians. And we moved from grappling with a complex problem in an individual to a complex problem in a population. But we had this unprecedented opportunity to eliminate hepatitis C through treatment. So here was another opportunity in 2005. Hospitals were invited to put in bids to run an operational delivery network for the treatment of hepatitis C. And on the back, perhaps, of our experience in clinical trials, we successfully negotiated with neighbours in South East London and Kings and put in a joint bid to roll out new treatments for our patients. And this resulted in, you know, very significant investment from NHS England and a generous annual sequin, which is a quality payment to the trust, which allowed a very significant expansion of our team. There was innovative commissioning with pharma who were involved in the whole effort to identify patients. So in 2015, we could treat decompensated patients. In 14 and 15 cirrhotics, and in 2016 we got to the desired steady state of being able to treat everybody. And this has seen a very significant shift in how we address this, from hospital to community, from doctor-led to nurse-led to pharmacist-led to coordinator-led to peer-led treatment. We have a fantastic team who now work in drug and alcohol centres, homeless hospitals, hostels, Wandsworth Prison, food banks, street locations equipped with this mobile clinic funded by NHS England. And we work with peers. These are people with lived experience who are invaluable in supporting us and clients to get together so we can do the testing and treatment. There's a long list of names. Some people have come and gone here, but I just want to credit everybody here who has, put an enormous effort over the last, 8 years now to access our patients. How have we done? Well, data is king, and we have great data because we're paid to collect it. We've treated 1,537 patients since 2015, and 30% of those people had advanced fibrosis or cirrhosis. 40% have been treated outside of hospital, in prison and community drug services, and on our van. And there have been very, very few virological failures. We have lost around 20% of this group to follow up, and we have a continual process of trying to re-engage with those people. But if we take them out of the analysis, we've had a 94% cure rate in real life working in those locations. And if we then look at the small number of people who didn't respond or who relapsed, who we retreated, there are only 2 people that we know of now in our whole community that have not had successful viral eradication. The program's ongoing. There's always new developments. Max is here. He's helped us start opt-out testing for hepatitis C and HIV in the Southwest London hospital emergency departments. And our team now is charged with linking all those people with new viral illness, hepatitis B, much more prevalent than hepatitis C, to care. So, viral hepatitis is not the only cause of fibrosis. Alcohol-related liver disease and fatty liver, this is the new term for fatty liver, also causes fibrosis. So why not try and look for those patients in the community? I mean, we have the staff, we have the facilities, and that's exactly what we've started doing. There was another call, another opportunity from NHS England and NHS Improvement to perform these community liver health checks using FibroScan. Michael's sitting at the back there. He's our main man with the FibroScan. So we go out with our van, we go everywhere like we did previously, and we're trying to pick up people with advanced liver disease. And this is what we've done, or what he's done and others have done in the last 18 months. We've screened nearly 2,000 people, and you can see that on these individual points here, this amazing curve. 11.5 is the cutoff we've been given. We're not sure it's right, but on the basis of this, we've detected advanced liver disease or cirrhosis in 7.5%, which is pretty good of the population that we're looking at. And now we're just grappling with what we're going to do with these people as they appear every week in our statistics. So I had lessons learned trying in parenthesis from my talk. I'm going to try and summarize those very quickly. I think the first thing is put the patient really at the center of everything we do. Watch them, measure them, look for change, look for small change, because that's how you learn about disease in the classical way that I've showed you, and also when new things happen, like in COVID, but also listen to them, understand why they want to be treated, if they want to be treated, where they want to be treated, how they want to be treated, who by. It's only through that process that you can really engage with a problem and deliver care. The second thing is opportunities. Look out for and then follow opportunities, and don't be scared to do so. And I think there have been some examples, and I think the one really I want to talk about is this virtual circle of research. We started doing some clinical trials, and of course not a huge team, generated new knowledge and treatments, but there was definite patient benefit. There was centre benefit as well. We developed expertise. We were asked to do more trials. As we did that, patients wanted to come to this hospital for treatment. People referred into us. This became the basis of commissioning for new services associated with money, with income. We could build our teams. We could recruit and retain excellent people. We could do more research as well as delivery with the associated income, and then plough that back into our service, but also to invest in academia and in research. And that's what we've been able to do. Who says business cases don't work? We wrote a business case and we managed to create this new senior lecturer post with the university. Manoj Singanagam, another extremely fine clinical hepatologist, but also a scientist and a liver fan. and an immunologist, is building a liver immunology group in the university. And I have to mention Joe Dilo working with Arj. First major success of the group. Joe got an MRC clinical training fellowship to look at the role of TIGIT immune checkpoint axis in infection and decompensated cirrhosis. We expect more, Arj. And then there were 5. And Metin, where's Metin? Metin is our latest consultant hepatologist and pancreatologist. And if you know Metin, you'll know that he's already a major pillar in our department, brimming with enthusiasm, trying to train and teach anybody that will give him half a chance. Are there any other lessons? Well, I increasingly find that I can't do that much on my own anymore. I mean, I can get ready for work and everything. But when I come to work, well, it's all about teamwork, isn't it? Everything we do is about teamwork. The achievements that I may have had or appear to have had really rest on the shoulders of others, the teams that I've been privileged to lead or be part of. And I realised at this point, I've only said the word gastroenterology once, or twice now, so 3 times. So I have to talk about this last team, my hollow organ colleagues. Here we are, all sitting. The breakfast. This was on the first junior doctor strike on the morning. We were girding our loins. I think only Penny's not there because she probably went off to get another round of coffee, so we didn't have to go to the walk. These are great guys, but they're not my favourite team. My best team was, of course, my home team. Mia, Henry, and Emmeline. Emmeline, I hope you're watching. She's in Germany. She started her job today. And of course, Julia, my wife. And they've provided so much support and advice and encouragement, and have tolerated me. They've tolerated quite a lot. Julia especially has managed to do all this, raise a family with me, run a household while forming her own career in education. So as much as I love my job, I love them much more. So returning to lessons learned, I think I've come to an end. So thank you all so much. Thank you all so much for this.
He's been watching.
No.
That has just been amazing. I think you just feel what you've done. It's just wow.
It's an amazing journey you've had, particularly with, I think, hepatitis C. I think there being very few researchers who've followed a disease from its initial diagnosis through to the effects that it has, and then through to the treatment, and then hopefully through to near eradication. Just an incredible journey.
I think a great professor needs vision and passion, which you absolutely have in Bucket Falls.
You're really clear thinking. You have the ability to think outside the box there. And I think the community outreach program that you've set up has really demonstrated that. You really know what you want to achieve and have the ability to actually achieve that. Occasionally ruffling a few feathers along the way. And you absolutely build for teams. So evident from all that you've spoken about. I think from, I suppose, within our department, I think one of the most humbling things that you did was get so stuck in around the tocilizumab during the COVID pandemic. And I really think how you actually led and really recognised how tocilizumab was going to actually help those patients really affected the outcome for the better for a lot of patients on the intensive care unit. And it was your leadership, really, I think, that sort of drove that. Camel's nodding. So you've been instrumental in linking the trust and the university together in clinical research and transforming clinical research at St George's Hospital over the last 10 years. And I think you have developed and you leave an incredible legacy in the unit, which hopefully will continue going forwards. I know you were particularly proud of your endeavours when Roger Williams asked you, I think, to be part of the Lancet commissioning group, and which you showed us, which is just, I think, shows again how well respected you've been in terms of that clinical and research hepatology. And again, you were amazing. You actually enabled St George's to actually be mentioned as a particular centre for that. What is amazing, and not many of you may know, is that Dan's actually done all this research alongside a full clinical hepatology post. And you've been able to see opportunities in research, but you've also been able to see opportunities within our clinical hepatology service. And Dan's made huge strides forward with the fatty liver pathway, particularly with our GP and our hepatology teams. So a number of years ago, I can remember sitting in a meeting with you, and we were talking about hepatoma treatment, and you went to the radiologist. You just need to do it, and they went and did it. And it was just great, leading again from the top. It's lovely that Professor Thomas is here. I think you actually did Dan's reference for his job. And I can remember back in 2005, this reference came through and it was just 2 lines. And it said, Dr. Forton is one of the best diagnosticians I know, one of the best clinicians, you must appoint him. Put the patient first at everything that you do. You're an amazing team player, and I think we've all benefited from working with you in the department. I think though, to reflect that you worked so hard that it wouldn't have been possible without your family, and particularly Julia supporting you. And I think that again is an amazing team that you've developed to be able to enable that to happen. We've now worked together for 18 years, and I think when you first started, there were just the 3 of us. And there are now more than 17, I think, hepatology people in the team. So it's continued to develop. And again, you just continue to look forward to Arja's appointment, just having that ability to actually look into the future and really want to continue the service to develop is incredible. There's so much more that could be said about Dan. It's just 5 minutes isn't enough time. But you get really, really stuck in. And I think looking at that, the acute medicine, I mean, many years ago, but how you sort of transformed that and continue to work to transform our service. As a colleague and a friend, you really are the best. You're incredibly supportive. I can't tell you how many times I've phoned down and said, I'm really stuck with the CRCP, come down. And he just comes. It's just incredible. You're endlessly enthusiastic. You constantly generate new ideas. You're always there to bounce ideas off. You occasionally can be challenging. You also challenge us. And You really do continue to help and support those around you. So, I mean, only this week in clinic, I heard you telling a very new registrar about how you start assessing someone with hepatitis B. So, you know, you're right at the grassroots helping still with them with in terms of training. The last thing I'd just like to finish with is perhaps one skill that you may not know about Dan, is that he should have been or could still be a travel agent extraordinaire. Because he's been responsible for sorting out the most amazing accommodation when we've gone on conferences for the hepatology team. And I think you also sort out the most amazing family holidays for your team sitting there. You love exploring, you love meeting new people, you love trying new things. And I think perhaps in parallel, those are all attributes of a great professor too. So from all of us here, thank you, Dan.